All right, we're going to go ahead and get started. Thanks everybody for joining today. For intros, let's go ahead and use the chat. Why don't we just go ahead and put our name and where you're joining us from in the chat. We'll use those for intros and to help with attendance. But we've got a packed session, so we've got 3 case presentations as well as a didactic presentation today. So we'll start with the cases. Jess, I'll pull yours up first, and then we'll get started. So hold on one second. Okay. All right, go ahead and take it away. I'll scroll down as needed.
All right, great. So like Jay said, my name's Jess Johnson. I'm one of the ID docs here, and I am the director of our OPAT program. So this case is, I thought was interesting since we're discussing duration. As we go through it, it'll make more sense. I think this is actually, okay, sorry. So this is an 82-year-old white male. He was, the antibiotics that we're proposing are vancomycin and rifampin. And the reason being that he has a prosthetic joint infection with hardware retained. So it says which antimicrobial therapy and why. I think that was a misprint, but what we were proposing was vancomycin and rifampin for 6 weeks versus an alternative therapy that may be safer in the outpatient setting. So our patient, again, is an 82-year-old male. He has a history of bilateral total knee arthroplasties that are pretty remote, right in 2016, left in 2018. He initially presented with symptoms of dysuria, was seen by, on the outpatient side of things, had a urine culture that grew MRSA. Because of that, he was started on linezolid. However, his symptoms persisted and he developed bilateral knee pain as well as cold chills, even with taking linezolid. His knee pain became so bad he couldn't bear weight anymore. And so about 5 days after initially developing symptoms, he presented to the emergency room. Here, basic labs were drawn, orthopedics was consulted, and in the ER, both of his prosthetic knees were aspirated. You can see the left knee had 14,500 white blood cells, 68% PMNs, 3+ Luke esterase positive. And the right knee showed 245,000 white blood cells, 76 PMNs, 2+ Luke esterase positive. So both suggestive of prosthetic joint infections. Gram stain and culture were sent of those. Blood cultures were obtained, and although he had gotten some outpatient linezolid, antibiotics were held. He was stable otherwise, and then the next day, taken back for bilateral DARE procedures on the knees. Past medical history, aside from what I mentioned, he does have some CKD, coronary artery disease, hypertension, hyperlipidemia, acid reflux. Surgical wise, except for his knee arthroplasties, he didn't have any hardware anywhere, had some cervical and lumbar discectomies for sciatica, and then had been admitted previously for a gram-negative bacteremia from cholecystitis and had his gallbladder removed. So you can see the medications, they're pretty typical things for a patient in his 80s with some coronary artery disease. He does have a penicillin allergy, which was really remote, and had tolerated multiple cephalosporins while admitted previously. And then on exam, again, vitals were stable. He did not have a fever, and his knees were just warm with mild effusions when they were tapped. You can see his labs show a good leukocytosis, white blood cell count of 16, a CRP of 253, and his creatinine was 1.4-ish, and he kind of fluctuated anywhere from 1 to 1.2. This was a mild elevation for him. So micro-wise, so like I mentioned, that urine culture 5 days before presentation was positive for MRSA. His admission blood cultures also ended up turning positive for MRSA in both sets. Repeats were again positive, but only in one set. And then after he had the DARE procedure, another blood cultures were again taken, and those turned out to be negative. His aspirate cultures were also positive for MRSA, as well as all of his OR culture samples from both a left and right knee. So again, as we kind of talked about, the diagnosis isn't really in question here. It's kind of what we do after that. So with his MRSA bacteremia being complicated, an echocardiogram was done, and a TTE was negative for any concerns of a vegetation or an endocarditis. So after he cleared his blood cultures, a PICC line was placed, and this is oftentimes when my team gets involved. So there's a PICC line placed, the patient is stable, he's on IV antibiotics in the hospital, and now we're trying to figure out what to send them home on that will be safest. In terms of social history that was pertinent, the plan was for him to go home with home health and self-administer antibiotics. So he had been getting rifampin and vancomycin inpatient. Questions that I brought up are, is he a candidate for oral transition during his course? After he completes his proposed course, would he qualify for suppression, and with what? And since we're talking about duration, how long would we decide to keep this patient on antibiotics? Any questions so far? Yeah, so when we got the consult, so my team got the consult for home antibiotics, the first thing that I saw was that he was 82 years old with a little CKD at baseline. So sending him home on vancomycin made me nervous. We asked our team, our care manager, to look into daptomycin as an alternative therapy. Unfortunately, the switch wasn't able to be made because of cost, which is usually the reasoning behind difficulty switching from the two agents. Or if they are going to a facility, not all the facilities will actually carry daptomycin because it's costly to them as well. So at this point, we're kind of stuck with an IV course of vancomycin based on cost, given that vanc is often the cheapest option for a MRSA infection. The other question, though, being is, okay, can we do this safely? So he had been doing well on the vanc inpatient. He was tolerating the infusion. What we had proposed was, could we do outpatient continuous infusion of vanc, which is something that our UPAP program has started doing within the last couple of weeks. So we proposed to put them on continuous vancomycin and rifampin. The reason I like continuous vanc is you can get a vanc random level at any time. It doesn't matter. And your target is very clear. Like, you just want it between these two numbers. You don't have to know what time the vanc level was taken. You don't have to know if they missed it. Like, it is very clear. The only trouble we've run into is just making sure that the line is flush before you take that random vanc level out, or else it'll be 300. And that gets a little confusing. The other question, so the rifampin, so he does have a prosthetic joint infection. We know that especially with Staph aureus, rifampin has been shown to be very helpful. We kept him on this. If we had continued, or if we were successful at the switch of daptomycin, Would we have kept him on the rifampin? I've seen some ID docs kind of go back and forth. I was wondering if you guys had thoughts. I would have kept him on rifampin, but there is some, information out there that dapto is a good treatment for biofilms as well. And our other question, so is he a candidate for oral transition? So Jay, if you don't mind actually scrolling down a little bit. So first step, or one of your first steps, is making sure there is an oral transition option. So as you can see, we're running into some resistance with our tetracycline, doxycycline, and Bactrim. Now he is sensitive to linezolid. So could this be a patient that is possibly an IV to PO switch? That was kind of something, because he was stable on the bank and because of his age and concern of the cytopenias with time. It's kind of something we're just keeping in our back pocket for if he runs into trouble. The problem being, so now he has 2 knees that have been replaced. He does qualify suppression, but we don't have a suppressive option. That, along with him having a complicated Staph aureus bacteremia, was our reasoning to probably push him through the 6 weeks as much as possible. Again, because with those knees, just having a dairy still has a prosthetic joints, trying to get as much IV or as much treatment as possible before switching him to a less ideal suppression with probably doxycycline.
How do you dose the continuous infusion?
Yes, no, that's a good question for me right now. So what we have been doing is starting usually with a gram continuous, and it's 24 hours. Most patients, we've actually had to bump up a little bit. So of the OPAT programs in the entire US, New Mexico is the only one that does it. And they have a very big rural population too. So their patients often will go far away. So they started using continuous infusion. So we approached BioScripts about doing it, and they said yes. So it's actually been great. It's really nice.
So it's not that if a patient's needing a gram Q12 in the hospital, you give 2 grams of continuous infusion.
Right. The transition kind of depends. Drew's on the line and he's worked with, I haven't dosed it for any of our patients yet. But it just depends. Sometimes the total daily dose is like a 1-to-1 conversion.
Okay.
But when we get the outpatient levels, we have had, I've seen we've had to bump people up or down. Drew, do you have anything to add to that from your OPAT experience with continuous infusion bank?
Yeah, sure. Sorry, I was actually unmuted the entire time, so sorry if there was some background noise. But
It's fine.
I've seen a couple of patients that we've kept on continuous infusion bank. Currently, our protocol for OPAT dosing when switching from intermittent infusion to continuous infusion is to calculate the patient's total daily dose. So say, for example, they were on a stable regimen of a gram twice a day in the hospital, and then subtract 500 milligrams from that total daily dose. So if they were to go home on continuous infusion bank, we would have, in most cases, recommended 1,500 milligrams every 24 hours via continuous infusion.
Is that 500 you subtract a factor of a patient's age, creatinine, body weight, or
so initially the factor we used was a factor of 0.6 of their total daily dose in the hospital, but as Jess had said, we'd seen several patients who had lower levels than we had anticipated by using that method. So I would have to defer to Mira, one of our colleagues in the office, for sure. But this method, subtracting the 500 milligram dose, ensures they do get a slightly higher dose than what would have been calculated versus if we multiply by a factor of 0.6.
It has been helpful so far. Like Drew was saying, we've had some underdoses. That's been most of our issue so far. But what others have found is like the risk of nephrotoxicity way lower. The only thing I brought up was, so now you have the bank continuously infusing. There's some, some nurses will say that bank is a little bit more like hard on your lines. So are these patients going to lose their PICC lines? We haven't seen that yet. And the studies haven't really shown that bank is more of a like caustic agent in terms of a line, but something we're just keeping in the back of our mind. Yeah.
Or two with the continuous flow versus the stop and start, if that would help keep it more open
Right.
too.
Yeah, that's smart. Yeah.
I am sorry, I was going to hop in here. I just asked Mira. So the 500 milligram subtraction from total daily dose is consistent with that New Mexico protocol that Jess was mentioning earlier.
Any other questions or comments? All right. Thanks, Jess. Appreciate presenting again. Joy, I'll go ahead and pull up 341 here for you. Okay. All right.
Thanks, Jay. Our first COPAC case is a 70-year-old male. We evaluated in the inpatient setting. Let's start with his history. So pertinent history of present illness is a patient that presented with generalized weakness. Blood cultures on September 18th grew MSSA in 2 of 2 sets with clearance of bacteremia achieved quickly on September 20th. He had a CTA of chest, abdomen, and pelvis that showed possible increased fluids, stranding around an ascending aortic graft. And this initially raised concern for aortitis. This was later thought to be less likely based on his quick clearance of bacteremia and evaluations by cardiac surgery and vascular surgery. He did have a transesophageal echocardiogram that didn't show any evidence of infective endocarditis. The time we evaluated him, he was receiving Cefazolin. So the proposed antimicrobial therapy is cefadroxil, 1 gram by mouth twice a day. And the reasoning being cefadroxil has good MSSA coverage, and it has high, greater than 90% bioavailability. So kind of moving on to tell more about the patient. So past medical and surgical history. He had coronary artery disease and advanced vascular disease. So it had an abdominal aortic aneurysm, status quo an open repair with aortic iliac reconstruction, peripheral arterial disease, status quo left lower extremity bypass, aortic dissection type A, status quo open repair with subclavian bypass, and thoracic endovascular aortic repair. His medical history also included diabetes. So his medications, his main medications were those directed at his heart disease and vascular disease. He didn't have any antimicrobial allergies. And go scroll down, his social history, it's not really pertinent. A very remote history of smoking had quite in 2025. Previously taught electrical tech and was training to be a technician. So on exam, he was afebrile, a Tmax of 38.3 earlier in his hospitalization. He looked well, had clear breath sounds, healed sternotomy scars, and did have a systolic ejection murmur in the aortic region. The review of his labs showed increased maximum CRP. A little earlier in his hospital course, it was approximately 200. At the time of evaluation, his white blood cell count was normal, and his CRP had decreased to 160 at this point. And I've already shared his microbiology information as well as his imaging. So microbiology was just blood cultures, and the imaging was the CTA. You can keep scrolling down, please. And then his transesophageal echocardiogram. He didn't have any central vascular access at this point, only had a peripheral IV line. So questions about this case, and I would appreciate involvement from the audience as well, answering them. So question comes up, right? We have MSSA bacteremia. What's the most likely source of the patient's MSSA bacteremia? Where would it have come from? Do we think it's all his vascular material or another source?
Yeah, so most of the time Staph aureus bacteremia is from a skin soft tissue. And I think there's some studies that say like a quarter you don't even know. So could it have been, knowing that it cleared pretty early, that makes me feel a little bit better that it probably wasn't all this like grafts and things like that. But what are your thoughts, Joy?
So this patient actually had a laceration to his scalp while he was out working in the yard. And so he felt, and we felt, that that was the most likely etiology of his bacteremia. So exactly what you said, a skin soft tissue source. So we thought this was a skin soft tissue associated bacteremia in a patient with severe vascular disease and a lot of endovascular material. So I agree with Jess. And the second question is, early intravenous to oral transition possible?
It seems like, so you would label him, he's like, I don't know, sometimes, but when you have between complicated and uncomplicated Staph aureus bacteremia, I feel like there's like this sort of like region, because because of his grafts and things like that, he's technically labeled as complicated, but he cleared really early. And we have kind of a good story for a laceration on the head that caused this bacteremia with cultures that cleared really quickly. So
I think you're putting the emphasis on the clearance, the rate at which the bacteremia clears. And I think most ID providers probably use that as the biggest factor. Somebody who's bacteremic for 8 to 10 days versus someone whose next set of blood cultures cleared. They're probably different phenotypes.
So yeah, we did transfer the transition the patient from IV to oral antimicrobial therapy. So he went from IV sulfasalin to oral cephodroxil in the 1 gram by mouth twice a day. So the higher dose. And again, cephodroxil has the high, greater than 90% bioavailability. And then, as we discussed, he cleared his bacteremia very quickly. So this kind of transitions into how long would we treat and why. So again, we thought this was likely a skin soft tissue associated bacteremia. Vascular material probably wasn't seeded, but was present. So he ended up receiving sulfasalin for 3 days, data from clearance of bacteremia, so made sure his blood cultures did clear, and then was transitioned to cephodroxil for the last 25 days to total of 4-week course. And so just a follow-up in this patient. So his CRP did normalize very quickly as we continued to follow labs. And at the end of his antimicrobial course at 4 weeks, his CRP was 2.6. And he was recently seen in IV clinic off of antimicrobial therapy when he was doing very well and felt 100% back to his baseline.
And I think I'm really looking forward to the presentation on duration, but I think sometimes we make up these numbers. You know, it's either going to be 2 weeks, 4 weeks, or 6 weeks.
Yeah.
And I can see why somebody would have said, oh, too much prosthetic material, maybe I'll do 6 weeks, but then rapid clearance makes you say, maybe you can pull back a couple of weeks here.
Yeah.
Would anybody have treated for a different duration?
I would have felt comfortable with that 4 week, and that would have been my thought process too. Would 2 weeks probably have been okay? Probably.
Maybe.
Yeah, but I would have maybe lost some sleep, so I would probably just push them to 4 weeks. One question I had, some patients like this, I've seen some providers request like repeat blood cultures like a week or 2 later. I feel like if a patient's bacteremic, especially with staph, they're going to tell you. But that was just one thing I wanted to mention or see what your thoughts were.
I agree with you as long as they're doing well clinically. He looked great and the MRP had come down. Do you mean 2 weeks like after stopping completely? Or
Yeah, after
I would
stopping,
think as long
yeah.
as he's back to taking his classes and working outside again and
Right,
back
yeah.
to normal, wouldn't feel that they would be needed.
Why make everyone worried when he has a gram positive because of that connecting to staff and yeah, go down that rabbit hole, yeah.
All right, let me, I'll switch it over here real quick. All right.
One more quick case. So this is a 62-year-old male who also evaluated in the inpatient setting with a bone and joint infection. And I'll give you his history and then go back to the proposed antimicrobial therapy. So this patient presented with right upper extremity edema and erythema after carrying a heavy object. Blood cultures in an outside facility on October 22nd were negative. And blood cultures after transfer to our facility the same day, October 22nd, and October 25th through MRSA with clearance of bacteremia achieved on October 28th. He had an MRI of his right humerus on October 29th that showed pyomyositis, findings concerning for right elbow septic arthritis with osteomyelitis, basically the distal humerus right at the joint of the elbow. MRI right forearm on October 31st showed right forearm brachioradialis extensor carpi radialis longus pyomyositis, as well as a large left elbow joint effusion. No evidence of osteomyelitis involving the radius or ulna. He underwent right elbow arthrotomy and synebectomy and right brachioradialis abscess evacuation with muscle debridement. So good surgery for source control on November 3rd when operative cultures through MRSA. And he was receiving daptomycin and had already demonstrated clinical improvement. So proposed antimicrobial therapy and why. So we proposed linezolid 600 milligrams by mouth twice a day. This has good MRSA coverage with high and 100% bioavailability. And for the skin soft tissue component, it has much better penetration or skin soft tissue coverage than vancomycin, which was also part of the reason when the patient was on IV therapy, daptomycin was chosen over vancomycin, but just a teaching point. So going on to his medical and surgical history, did have a tubulovillus adenoma, high-grade dysplasia, and had a right hemophilectomy. Drinks some alcohol, used some smokeless tobacco, and occasionally smoked meth. No medications prior to admission, no known allergies. And social history I kind of already shared. In addition, he retired from the oil industry. So in physical exam, he was afebrile later in his hospital course. He did have a high fever with a Tmax of 39.4 degrees Celsius earlier in his course. He was non-toxic of hearing, breath sounds clear, no murmur, and then had right upper extremity edema and erythema. And Jay, do you want to scroll down to the pictures? Or the first picture at least. So this is the first picture. So this is taken early in his hospital course. You can see swelling redness. And then you can show the next one as well. You don't want to, thanks. And this is later in his hospital course, and this is a picture of the improvement that he had even pre-operatively. So.
Afterwards.
So his labs, his maximum CRP was high at 411. White blood cell count around the time that we saw him or made our antimicrobial recommendation was 12,200. CRP at that point had come down to about 24. And I already shared his microbiology information. So basically my blood cultures had grown MRSA with clearance achieved, and then went to surgery with growth of MRSA in 1 of 2 specimens. The imaging we discussed as well. He additionally had a transthoracic echo because of the MRSA bacteremia that showed, normal findings, no evidence of endocarditis, and he had a peripheral IV line. So the main questions about this case. So again, is intravenous to oral transition possible, or early intravenous to oral transition possible? Would we, keep this young or middle-aged man on daptomycin, or would we switch over to linezolid?
Feel free to unmute or use the chat.
There are a few things that kind of made me feel like he'd be a good candidate for linazolid. He is pretty young, and overall healthy, not on a lot of medicine, so not a lot of chronic conditions that are kind of underlying. I think more of switching him to linazolid would be making sure that he's reliable. So is he gonna be someone that takes it like he's supposed to and gets follow up like he's supposed to? Those were just my thoughts.
So the patient was transitioned from daptomycin to linezolid. Again, the reasoning, he did have excellent source control, through surgery, and for the reasons that Jess shared as well, thought he was a good candidate. And he was treated with almost all oral regimen after source control. And linezolid, as I shared earlier, has about 100% bioavailability. So kind of going into the next question, how long would you treat this patient and why? So I already kind of mentioned he had excellent source control through his surgery. So any thoughts?
With the osteo, I might say somewhere between 4 or 6 weeks or 4 weeks-ish. But I think in these patients, especially, like watching your CRP could be really helpful to kind of figure out how long a duration is appropriate. Might even be like, we'll aim for this, but we'll see what your labs show kind of thing.
At the time of discharge, he was treated with a total 3 weeks of antimicrobial therapy postoperatively, consisting of daptomycin for just a couple of days as he was getting ready for discharge, and then linazolid on hospital discharge for the last 19 days. And the thought process was that great source control was achieved through surgery, and the upper extremity, we thought it was mainly a septic arthritis. With imaging that did raise concern, and the elbow joint for possible osteomyelitis, but because he had such good source control, tried for the shorter duration. And in follow-up for him so far, his CRP has decreased so far to 14, and this point was pretty soon after hospital discharge, so he still had 2 weeks of antimicrobial therapy left. So we are trending the CRP. He did have significant improvement clinically, as shown in the picture, even preoperatively, and then he's continued to do well so far. But he is scheduled for follow-up, where we'll kind of plan the definitive duration, but still on track for 3 weeks tomorrow.
I had him on my medicine service, and I think, it was impressive how much improvement had occurred before definitive source control. The pictures looked much better. He was non-toxic. And then with MRIs, especially in an acute presentation, I'm always a little worried over reading MRIs for osteomyelitis, where his clinical presentation was very much pyomyositis with or without a septic arthritis. So again, time will tell whether you chose the right duration or not. But since this is a presentation on duration of antimicrobials, we thought we would share one where it was maybe a little shorter and might need close follow-up.
What was cool about that patient too was you have like blood cultures that are negative and then that are positive. It kind of shows you how long that has been festering, I guess.
Correct.
You know what I mean?
Yeah.
It's very low grade, but then repeats were positive at the looks like 72-hour mark. So, that's where you get in that gray area. It's very low grade, and he was not bacteremic at one point in the day, but was later on the 22nd. So
He looks better. Yeah.
a complex case for sure.
Yeah.
Any other final thoughts or comments? No? Okay.
And didn't have a very definitive etiology for his bacteremia. He did give us a story of he was working with his hands that may have had some cuts and things like that.
Yeah.
So,
Yeah, that
like mentioned, skin soft tissue tends to be the most likely point of entry.
Okay. All right, thanks, Joy. Appreciate it. We are going to then switch over to Contessa. I'll pull up your slides for the didactic, and we'll get to the duration stuff. We've waited our duration, and now we will get to the slides. I couldn't. I had to. I apologize.
Well, thank you, Jay. While you're getting those pulled up, I'll introduce myself since I'm a guest today. I'm Contessa. I'm our lead antimicrobial stewardship pharmacist for the health system. And to follow up these very nice case presentations, I'm going to be talking about how low we can go in durations of antimicrobial therapy. So I'm going to be hitting a lot of high points, but certainly open for questions after this. And if it's something we don't get to in time today, feel free to email me. All right, but we can go ahead and get started. Just for time's sake, on the next slide, I'm not going to go over the objectives, but definitely going to tie in the antimicrobial stewardship role in determining durations of therapy, discussing the consequences of prolonged antibiotic use, and also looking at literature promoting shorter durations for common infectious diseases. So next slide. First, I always like to start every talk I do with our W Medicine antimicrobial stewardship motto. And this is not unique to us. This is really adapted from IDSA guidance on antimicrobial stewardship programs. But when I think about stewardship, it's not just de-escalating or just stopping antibiotics. It's the right antimicrobial for the right bug at the right dose and route, OPAT, COPAT. And today, we're going to be talking about for the right duration. And all of that goes into stewardship. And you might be thinking, well, I don't directly practice in stewardship every day. But the great news is if we go to the next slide. Actually, we have the next slide after this, but we'll talk about this one first. You can go on the next slide, Jay. When we determine that duration of therapy, is that a part of antimicrobial stewardship? If you actually look at the 4 moments of antibiotic decision making that was put out by the Agency for Healthcare Research and Quality back in 2019, the fourth, but definitely not the last nor least, portion of stewardship in the acute care setting is determining that duration of therapy. So that should be made, before the patient is discharged. We really should be thinking about that all along while we're working up the patient. But then once we have all of our information, determining at least that soft duration of therapy, like we've talked about today with some of the cases. So now you may be thinking, well, I don't practice in stewardship every day. But that great news is on the next slide, everyone is an antimicrobial steward. So if you touch antibiotics, if you monitor people on antibiotics, prescribe them, you can be a steward of these resources, absolutely. So that's what I always like to empower everyone with. If we go on to the next slide, if you're practicing in stewardship or not, why can't I give antibiotics forever? Why can't we just give these for these very long durations? And there is a whole slew of reasons, but the things we're going to focus on today really is adverse effects. So I've been practicing only for 5 years now. If you count the COVID years, I think each one of those counts for about 10, especially with the antibiotics we used during that time for concomitant infections. But I'm never surprised by adverse effects that I see on antimicrobials. When I've called people on OPAT and COPAT and they've told me their side effects, I may say that's not typical, but it's not unreasonable. So let me look into that for you. Antibiotics are not benign. Especially when given for longer periods of time, we see increased adverse effects. The second and probably even more important is the development of antimicrobial resistance. What has always drawn me to infectious diseases is if I give a patient antibiotic today, that not only impacts them, but that impacts future choices for future patients. It impacts the ecosystem around us. So the longer we're using antimicrobials, our bacteria are smart. They're developing resistance mechanisms. They're developing tolerance to our antimicrobials. And we really only have a finite number of antibiotics in particular. So I don't want us to be like the Brachiosaurus listed here and be extinct, our antibiotics to be extinct in the future. So we really need to preserve this very limited resource that we have. And if we give more antibiotics over time, we will have decreased resources for the future. So these are my top 3 reasons on why we just can't give antibiotics for a very long duration. But of course, we increase the cost of healthcare for the patients. We increase complications and everything associated with that. So going on to the next slide here, I always like to talk about where we got our durations of therapy from. The Roman Empire has certainly given us a lot of great things and really made us into the modern world we are today. But if we think back all the way to the year 321, the Roman Emperor Constantine the Great said there's going to be 7 days in a week. And that has perpetuated over time, especially in the medical world. And that's where we just get these 7-day durations of therapy for a lot of our infectious diseases. We think it's when we conduct clinical trials, it's very easy, 7 days, 14 days, 21 days. We're just counting by 7 in these senses. But really, what is that based on other than just that's how many days there are in a week? So let's explore that a little bit further by going into the next slide. In the 1940s, that's when penicillin was discovered and made available, and this changed the world. Antibiotics certainly, I haven't mentioned it, but they are life-saving when used appropriately, of course. So when penicillin was put out there and used, we looked at durations. We look back at durations of therapy for pneumonia. This would range from a day and a half to 4 days, pending the patient response. But then treatment would be extended for an additional 2 to 3 days. So 7 days there. We're doing 4 days depending on the patient's response to prevent relapse. So the physicians at the time were like, okay, you're better, but I don't want you to get worse again. So here's 3 additional days of therapy of this penicillin. So that really ingrained this whole thought process of you must finish your antibiotic course to prevent resistance. And I was taught that in school. I've learned that for years and years, but there's really no evidence to suggest that this actually does prevent resistance if the antibiotics are stopped after the patient is clinically better and completed a course that's efficacious enough, proven by literature for the infection that we're treating. So, we may start with, in some cases, we may start and say, oh, we need 6 weeks of therapy for this, but the patient follows up at 4 weeks, they're doing great, we can stop. And alternatively, a patient could follow up at 4 weeks and then not be doing great. Well, we can extend. All of this to say, it's all very much made up and it's very patient specific. It should be patient specific. But I like to go into a little bit of history of this because really all of our durations of therapy have kind of come from, this is a calendar week. And here we are. So this, 1940s, we have penicillin, changed the world. This is what we're doing. From then on, about to the early 2000s, we had very long durations of therapy. We had 2 to 3 weeks for very common infectious diseases. But then in the early 2000s, we started to see this emergence of literature surrounding shorter durations. And I would say in the past 10 years, that's definitely grown to a plethora of information. If we go on to the next slide, we can see here, this is one of my favorite charts. I put it in every talk I do surrounding durations of therapy. But this comes from a ID physician out of California, Brad Selberg. He is a big proponent for shorter is better. And I love his website because he compiles all of this data looking at short courses of therapy versus long durations of therapy and sums up the literature very nicely. If we take a look at this chart, we can see that there are many diagnoses on here. Everything from community-acquired pneumonia down to post-op prophylaxis. We even have malaria on this chart. I mean, there's a lot of things included here. But a couple of things I want to draw to our attention is that from these 20 conditions, we have over 130 randomized controlled trials that looked at short durations of therapy compared to long durations of therapy, and all of these have been equal. ID is a sect of medicine. We do not get a lot of randomized controlled trials, so when we get them, we really have to analyze them and really take them and use them to hopefully propel practice and change practice in the future. So having 130 of these is really fantastic. And I wish I had time to go through every single one of these today. but I don't. So I'm going to highlight a few of them. If we go to the next page, I've called out a few in particular I'd like to highlight. So ventilator-associated pneumonia, I want to just call quick attention to this. It has there's been a couple of very specific trials that looked at 8 versus 15 days of therapy. So breaking that 7 versus 14-day rule. But what they found in our VAP patient is that a short course of therapy of 8 days was equal to 15. And that even includes Pseudomonas, ventilator-associated pneumonia. So while that can be a difficult to treat infection, if the patient is clinically improving at day 8, there's no reason to continue that therapy as long as the patient's clinically improving. And I think that this is important to pull out because it's something, if we're working in a hospital setting, especially if we have ICUs, that's going to be something that we encounter from time to time. And these patients, even though they may be very sick and on the ventilator, they really can get by with shorter durations of therapy if we look into the literature. The other one, if we kind of scroll our eyes down to the bottom of the chart, is we're working in settings that we're doing surgery, so post-op prophylaxis. And I'm going to pull this one out just for one reason. The fact that there is 55 randomized controlled trials that show that no antibiotics after surgery up to 1 day is equal to 1 to 5 days of therapy. That is just the plethora of literature to support that. And we may think that, well, it's only ANSAP. Well, it might be, but that 5 days of therapy can really count up. So there's a lot of information out there regarding that. I definitely can't go into that in depth. But just wanted to pull that one out as well. The other two I am going to actually dive into are the intra-abdominal infections and gram-negative bacteremia. So starting first with the intra-abdominal infections, if we go to the next slide, I think that this trial in particular does a very good job at defining where we got these short durations of therapy from. So this was the Stop It trial, which I thought was very cleverly named. But this came out in 2015, published in the New England Journal. And this looked at a trial of short course antimicrobial therapy for intra-abdominal infections versus a longer course. So we go to the next slide here. And Jay, this is the one with a few animations if you would care just to click through them so they all pop up on the screen. Perfect. What this did was it compared a control group that received antibiotics for a max of 10 days post-source control, a median of 8 days of therapy, versus an experimental group that received antibiotics for a fixed 4 days post-source control. And it compared these two groups looking at a composite endpoint of surgical site infections, recurrent intra-abdominal infections, or death within 30 days. And what they found was these were equal in terms of therapy. And when you think about source control, I get a question a lot when I'm recommending this, when I'm doing stewardship reviews. Well, the patient just has a drain in their intra-abdominal abscess. Is that source control? And if you actually look through the Stop It trial, a majority of the patients achieve source control through percutaneous drainage, actually. So yes, that counts, absolutely. The only thing I do point out, this sometimes gets extrapolated to hepatic abscesses, like pyogenic liver abscesses, and those actually weren't included in this trial. So it's important always to tease through these and see what the inclusion-exclusion was. But this really, I think the Stop It trial really kind of changed our thought on a lot of intra-abdominal processes. If we achieve good source control, a longer duration of antibiotics really doesn't do much, especially in the terms of surgical site infection, recurrent intra-abdominal infections, or mortality, which is really what we're most concerned about. So I want you guys to keep these days in mind. So 4 days versus 10 days, and you may think that 6 days may not really matter. I've got some slides coming up that will make you think differently, that 6 days of therapy certainly matters. So that's the intra-abdominal information I wanted to go through. But now I'd like to switch gears on the next slide and talk about our uncomplicated gram-negative bacteremia. I feel very partial to this because this came out when I was doing my residency, and a big project one of the first stewardship projects I worked on in my career was developing our guidance document on 7 versus 14 days of antibiotic therapy for uncomplicated gram-negative bacteremia, and switching people to oral therapies sooner in these situations. And the reason I want to pull this one out is this was uncomplicated gram-negative bacteremia. Up until this trial being published in 2019, it was just kind of this thought that we treated for 14 days. There was no great literature out there to even support 14 days of therapy, base it off the source, but the source is often urinary in nature, it could be intra-abdominal. There wasn't a lot of great literature to even support that longer duration. Then this trial came out, and this was a very pivotal trial for sure. So I'm not going to get into the nuances of this trial just for the sake of time. But if we go on to the next slide, the one thing I want to point out with this, is that, we've established that efficacy is the same for short versus long durations of therapy. So 1 week versus 2, all the same. But the two things I do want to point out that this trial looked at that not many have done is the first highlighted box, the functional capacity. So needs assistance or dependent in activities of daily life or bedridden in 30 days was statistically higher in the long arm therapy. So 6% difference. Those that received 14 days were more likely to need assistance at 30 days after treatment. And then conversely, if we look at time to return to baseline activity at 3 months, and this was statistically significant, the people in the short arm were much more likely to return to their baseline activity within 3 months versus the long arm therapy. Now you could think that could have just been chalked up to patient differences, but the demographics were very similar between the two arms. So do shorter durations of therapy actually get our patients back to functioning quicker? This would suggest so. So I just think this is something to keep in mind. We can think about outcomes and mortality, and those are very important, but also what's important is getting our patients back to their daily lives. And this is what this study looked at. So I'm going to go ahead and go on to the next slide here. Every day counts. I mentioned, 4 versus 10 days of therapy, that's just 6 days. If we do 7 versus 14, that's just a week. There's been a couple studies come out looking at each day of an anti-pseudomonal beta-lactam actually increases your new resistance by 4%. So even with just 3 additional days of therapy, you're almost a quarter more likely to develop new resistance with that longer duration of therapy. Additionally, on the next slide, this is a meta-analysis that came out not too long ago in 2021 that looked at short versus long durations of therapy trials. And what they found was with each additional day of therapy, you increase your rate of adverse events by 4%. You increase your rate of antibiotic resistance by 3%. Now, the last slide was just looking at anti-pseudomonal beta-lactams. Oddly enough, they did find that the superinfection rate did decrease by 2%, but that was not statistically significant. This was a very mixed cohort of studies. So I would argue that every day of antibiotics increases your rate of C. diff. There's many studies that prove that. But one thing I do like to look at too is on here is, each additional day can cause harm to our patients. So if we look at 7 versus 3 days of therapy, we're at a 20% increase of adverse effects with the 7 days. So when we think about that 4 versus 10, that's a very big increase of adverse effects. And what we don't want to do is impose harm on our patients. So going on to the next slide. Determining day 1 of therapy is key to deciding the duration. I'm not going to go through this just for the sake of time, but a lot of stewardship is figuring out what day 1 is. And one plug I want to put in here is counting those inpatient days of therapy on discharge as well. One thing I've seen a lot from a stewardship perspective is people get discharged with antibiotics and they get the whole course again. We don't count the inpatient days, so those days definitely count. Going ahead and we'll just skip over these. There are exceptions to the shorter is better rule. There are certain things that have not been looked at for shorter therapies. They're listed on this slide here. IV is a very gray area, and we always need to take our patient into consideration. But these are just some things that haven't been studied for short duration of therapy, quote unquote. Going to the next slide, just one thing, keep in mind with durations is Antibiotic Awareness Week starting on later this week. So think about that when you're prescribing antibiotics and picking duration.
Thank you.
Yeah, absolutely. And I am so sorry, I have to jump to another meeting.
Okay.
But I really appreciate you guys having me today. And if anybody has any questions, happy to answer those at a later time.
Thanks, Tessa.
Great, thank you.
Appreciate it. Yes, and we'll share the slides. You also have the recording. So if there is any follow-up, we can handle that. I see we're at time at 1 o'clock. We'll meet again in December on the 12th before the holiday, and then we'll meet back in January. So until then, if there's anything we can do or any questions, please reach out. And if not, we'll see you in December.
Thank you very much, and appreciate Princeton showing up. Thank you.
Yeah.
Thank you.
All right. Thanks, everybody.